I'd like to welcome you all to the Lion tonight for our meeting. Our meeting today is being held on the traditional lands of the Goanna people of the Adelaide Plains, and I wish to acknowledge them as the traditional owners of this land. I'd also like to pay my respects to their elders, past and present, and the elders from other communities who may be here today. Additionally, I'd like to give special thanks to our sponsors for tonight's meeting, Merck Sharp and Dome, Pfizer and Seqirus. And I would like to introduce our guest speaker this evening. Dr. Stephen Lam is a senior consultant in critical care medicine at Flinders Medical Centre, Ashford and Flinders Private Hospital. He has an interest in cardiopulmonary resuscitation and ECMO as chair of the Flinders Medical Centre Medical Emergency Response Committee. He is a board member of the College of Intensive Care Medicine and was formerly an aeromedical consultant for MedStar and member of the Critical Advisory Board for AstraZeneca on antimicrobials in critical care. If he got $1 for every time he was told by a patient or relative or colleague he looked too young to be a specialist, he could have retired several years ago. I'd like to present Dr. Stephen Lam. Thanks.
Thank you very much. Actually, it was only just last Sunday that I got asked by a patient's relative, say, how many more years of training before you become a specialist? And I said, I've been a specialist for 12 and a half years. And then midlife crisis just took another step up. I'm very grateful for being given the opportunity to come and talk today. I really got looked after very well during my anaesthesia training time, having come from physician training at the Royal Adelaide way back in 2002. So I hope that I might have something to give back to anaesthetists. Now, as much as I'm grateful to come here and give this talk today, it's a little bit frustrating because sepsis is the sort of topic that completely disarms an intensivist in terms of being able to look like an absolute smartass. And if any of you work with intensivists, you know that is a really painful thing for us to endure. And when I started, I got asked to talk about sepsis and I thought, of course I can talk about this, there's a lot to talk about. And then when I started writing it up, I thought, how do I cover pathophysiology and clinical implications in 45 minutes? I thought, well, I could just flash stuff up that just makes you go cross-eyed, because that's certainly what happens to me. And when you look at stuff like this, I think, am I looking at those magic eye things where you go cross-eyed and all of a sudden the dog's poking out at you? But I thought if I spent an hour on this, then basically we'd be looking at this for an hour. So when I spoke with one of your colleagues last Friday, he said, look, Steve, I just want to hear the bottom line. And I thought, okay, well, I'll try and nail it down to the bottom line. It would seem a bit strange for you to walk out of a 1-hour session on sepsis and not have heard about the definition changed in 2016, as well as the Surviving Sepsis campaign. If someone says, oh, what do you think about the new definition of sepsis? And you go, I didn't know there was a new definition of sepsis. And then when they said, well, the Surviving Sepsis campaign says, and someone says, oh, you don't believe that industry rubbish, do you? You say, what industry rubbish? So we'll cover that very quickly, but that's the boring sort of stuff. When we get to the bottom line, of course, what you guys want to hear really is the blood pressure's low, what do I do? Okay, I've done everything that the guidelines say, what else do I do? And then the 3 nightmare scenarios, and this is where hopefully I'll be able to give you something that you'll walk away with. Am I missing something that the intensivist is going to yell at me about? Now, I know most of you guys don't worry about this because we usually make a big song and dance and you guys just walk out of the unit going like this, and the intensivist is going like this. And but here are the really ones that worry you. Oh my God, I don't think we're even going to make it back to the ICU. And that really worries an anaesthetist, I know. And the biggest nightmare scenario is the med student just asked me a question and I don't know how to answer it. So I'll tell you how to answer a med student question like an intensivist. Okay, so the sepsis definition, won't spend a lot of time on this. Back in 2012, Society of Critical Care Medicine got together and they said it's probable or documented infection with systemic manifestations. So if you've got a cut on your finger, it's red, that's an infection. But if you've got tachycardia and you can't breathe and your kidneys have disappeared, then that's sepsis. And Roger Bone's criteria that he and his consensus meeting published in 1992 formed a very good clinical basis to define what a septic patient looks like. That's very easy to remember, and if you look at all the clinical trials, that's how they define sepsis. Now, as with time, not everything gets better, and I have no idea why you want to make KFC with no bones, but that's essentially what the change in sepsis definition did. They took out the bone criteria and said that the definition of sepsis is now a life-threatening organ dysfunction caused by a dysregulated host response to infection, which makes it very difficult to diagnose because you think, Well, have they got a dysregulated host response to infection or not? Well, what they're saying is there's three critical components to sepsis. You've got to have an infection. The host response plays a part in developing organ dysfunction. And what they're talking about here is a systemic inflammatory response, but also this compensatory anti-inflammatory response syndrome that occurs as well. So previously they'd defined severe sepsis as being sepsis plus sepsis-induced organ dysfunction, but now we're saying organ dysfunction has to be a part and parcel with the presence of sepsis. And so now they've said it has to be an increase in baseline SOFA score of 2 points or more. So now all of a sudden you've got to remember what the SOFA score looks like. So you've got to carry that around in your head now and calculate it and say, has it increased by more than 2? So guidelines and reviews, I love the fact that we've got guidelines because you can disengage your brain and just follow the guidelines. And I remember someone once said to me, guidelines are there to make a bad doctor better and a good doctor worse. And I think there's some weight in what they say. The Surviving Sepsis Campaign international guidelines were first published in 2004 and then revised a number of times since then, right up until they updated it in 2018. But it has not been without its controversy. So essentially, there are problems with sponsorship. And essentially what happened in 2001, a couple of key articles came out. The first was the PROWESS trial, where this extremely expensive drug came out called Xigris that basically found an improvement in survival. And really in sepsis it's so difficult to find something to improve survival that as soon as this paper came out they said, oh geez, we need to come up with a guideline that makes people use it because it's so expensive that people don't really want to use it. And then also in 2001 was a RIVERS study which basically said, look, when you diagnose someone with sepsis, you've got to keep giving them fluid, keep giving them vasopressors until you get the central venous oxygen saturation of greater than 70. You want their MAP greater than 65 because the amount of time spent with a MAP less than 65 portends a poorer prognosis. And you want to transfuse red cells until you get their central venous saturation up, and you want their central venous pressure up around 8 to 12. And when they gave people these targets to aim for, in other words, if you haven't achieved it, keep going harder, they found an improvement, quite a dramatic improvement in survival from 46 to 30% with a very significant p-value. And so they figured, well, we should make people do this. And so they gave that a grade B recommendation in the first guidelines that came out. To put it into perspective, they copped a bit of criticism because giving antibiotics and source control got a grade E, but that was just on the basis of levels of evidence. There's no equipoise to perform studies, and so you're never going to get much more than grade E according to their recommendations. So there was a little bit of criticism they got from that. The New England Journal then published an article about its concerns over sponsorship, and when you read the potential conflicts of interest, it's quite extensive. And they said that they had concerns about the fact that the company that made Xigris was the major sponsor of these guidelines that told people you have to use Xigris. Then what came out was the ADDRESS study that came out in 2005 and said if they've got a low risk of death, it doesn't improve their prognosis, but it makes them bleed a lot. And then in 2012, in patients with severe septic shock, not only did it not reduce mortality, but it also made them bleed a lot. And so what happened then was they withdrew it from the market, and all of a sudden a very big component of the Surviving Sepsis campaign disappeared. So protein C was then out. What happened then was they still recommended that we go for these resuscitation targets and so on and push forward with that. And then a series of publications in the New England Journal then found that actually standard care was no better than driving for these targets. And so what suddenly happened was the second major part of the Surviving Sepsis campaign guidelines suddenly disappeared, and it turned to this sort of shadow of its former self where they said, well, what you've got to do is you've got to measure the lactate, and if the lactate's greater than 2, then you should re-measure it. That's a weak recommendation with a low quality of evidence. You've got to take blood cultures and give them antibiotics, and then you should give them some fluids and then give them some vasopressors. Sepsis guidelines. All right, so let's talk about septic shock. This is the thing that worries everyone, right? Hypovolemia, vasodilatation, myocardial dysfunction, what it boils down to. We'll talk about intravenous fluid therapy. Now, the first thing we've got to spend is a couple of minutes talking about the glycocalyx, because most of us will be familiar with the Starling sort of equation talking about plasma oncotic pressures and giving people albumin and then giving them furosemide to try and draw fluid out of the circulation. That's now been revised. So We now think that there's this sort of brush layer on the endothelium, which forms a very important layer whereby it has an equilibrium between proteins in the plasma and the glycocalyx, which most of these, of course, is going to be albumin. It also opposes hydrostatic pressure extravasation, and there's this space in here underneath the glycocalyx. This is the endothelial cell. There's a space here which does not have any proteins. The proteins are continuously being taken out of that into the interstitium. And so this notion that the proteins here in circulation are going to draw fluid from out of here doesn't make sense all of a sudden, because there's actually a space here that has actually got no proteins in it. These proteins, so there's a proteoglycan that's got glycosaminoglycans that are bound to it, and it binds albumin, antithrombin 3, and a number of other things. So heparin sulfate is one of the proteins that binds to it, and of course that then binds to antithrombin 3 and prevents microvascular thrombosis in the vessels. It also binds some antioxidants to prevent oxidative stress, and also the glycosaminoglycans inhibit endothelial adhesion of platelets and red cells, prevents interaction between white cells and adhesion molecules, and prevents shear stress of nitric oxide production. It follows then that this is a really key role of the glycocalyx. Now, what happens when you damage it then is you'll lose those functions. So atrial natriuretic peptide, ischemia, reperfusion injury, cytokines and endotoxins, various things will do it. This is by no means an exhaustive list. What they'll do is then they will induce, amongst other things, endothelial cellular adhesion molecule expressions. These will then cause white cell recruitments. They then liberate matrix metalloproteinases and various other things that will start to break down the glycocalyx. And then what happens is then you get a very leaky membrane. So what you get then is, when you lose all of the functions of it, you've lost a protein equilibrium, you've now got increased permeability of proteins and fluid through the endothelial cell clefts. You get loss of the antithrombin 3 effect, so you start to get microthrombosis and platelet activation and clumping inside the vessels. You also get white cells now starting to pass into here and blocking up the vessels and migrating into the tissues. And you also get nitric oxide production and oxidative stress. Now this is normal, so if you've got an infection in the tissues here, you actually want white cells to migrate into there. You actually want nitric oxide to vasodilate that vessel and improve blood flow to that area of the tissue. So this is actually what you would expect and want to have happen. So why is this relevant when we're talking about fluids? Let's talk about albumin first. So albumin, of course, is a vital part of the structure of the glycocalyx. And not only that, but it's responsible, of course, for creating plasma-oncotic pressure. It's an antioxidant by binding iron and copper and stopping it from being involved in redox reactions. It scavenges reactive oxygen species and nitric oxide as well. It's also a transport and binding protein, so it binds to antibiotics, calcium, cortisol, thyroxine, a number of other molecules, of course. It's a weak acid, so it participates in buffering and acid-base balance. It also has some anticoagulant effects very similar to heparin, but to a much lesser degree, as well as inhibiting platelet aggregation. It's got anti-inflammatory and anti-apoptotic effects by promoting the anti-inflammatory versions of eicosanoids, which you'd be familiar with, such as thromboxanes and prostaglandins. But this notion where if you transfuse albumin, it gets retained in the circulation better, well, certainly it has been shown to be very effective in lifting the central venous pressure, but unfortunately, if you look at what happens in sepsis, the transcapillary escape rate of albumin out of the capillaries is quite quick, and then as soon as you give them 20% albumin, it continues along the same trajectory, so it does not actually retard protein loss from the circulation. When we look at the SAFE study, then this is a very key study because it's still one of the best ones out there. Patients who were assigned to either receive albumin or saline, and it was a blinded study for the study fluids, the albumin group actually received less resuscitation fluid than the saline group, significantly less. They had the same blood pressure and they had higher albumin levels. So what does that mean then? Well, in their subgroup analysis, the patients with severe sepsis with a p-value of 0.09 almost had better survival, but actually they then went on and did a proper subgroup analysis where they corrected mortality for baseline covariates and found that the p-value was now 0.03. Now it is a subgroup analysis, but the relative risk of death it did reach statistical significance, and it was less using albumin rather than saline. The patients had the same blood pressure, but they had a lower heart rate, they received less fluid, and they had a higher CVP and albumin level. Now, the role of albumin in meta-analysis also came out favourable, but there was an author that accounted for a lot of that data, which was called Bolt. And if that name doesn't mean anything to you, we'll come back to that name in a tick. But essentially, we don't hold the same weight for this meta-analysis as we do for the SAFE study. So we'll talk about starch then, speaking of Bolt. So it makes sense then to use high molecular weight starches. If you think of albumin with a molecular weight of 66 kilodaltons, these starches have a very high molecular weight, and maybe they exceed the size of the hole that the albumin is escaping from. The problem with starch, though, is that it's absorbed into tissues like the liver, spleen, kidney, heart. It's uptake by the reticular endothelial system. It's supposed to be excreted in urine and bile, and it needs to be degraded by amylase before it can be small enough to be cleared by the urine. The problem then is it does accumulate, and it causes quite a really bad itch. It's only partially degraded, and not that much of it actually comes out in the urine when you look at it over about 72 hours. And it also adversely affects von Willebrand factor, and platelet aggregation has been linked to quite a lot of bleeding. So Joachim Bolt published a lot of stuff on the starch, and it turned out after some people were looking at his raw data that it didn't look like it made sense. And as it turns out, he fabricated a lot of the data that he published upon. And so a large number of his studies were withdrawn. And in fact, it was said that the withdrawal of almost 90 fraudulent studies by this anaesthetist was one of the biggest cases of academic fraud in history. And so starch has sort of gone out of favour. In addition to which, this New England Journal publication also found that there was an increased risk of death using header starch, and they were also more likely to need renal replacement. So starch is a little bit out. What about 0.9% sodium chloride? Well, as one of our research intensivists in our department says, there's nothing normal about normal saline. The most important thing to look at really is the chloride, though. The chloride is nowhere near normal. And you might say, well, big deal, so what? It is associated with hyperchloremic acidosis, so in an acidotic patient it will lower your pH somewhat more. It has been linked to reduced renal blood flow and more kidney injury, as well as activating tubulo-glomerular feedback, which of course is one of the two mechanisms of the kidney auto-regulating glomerular filtration rate, so you get a predictable reduction in GFR. And it's also been linked to pulmonary edema and bronchial congestion, which we'll talk about in a tick. So we can tell that not only is the absolute level of chloride that occurs, but also it's the change in chloride that's associated with greater renal injury. And that in this study that Ronaldo Bellomo's group, along with UNOS, found was for a while they used whatever they wanted. They include chloride-containing fluids such as normal saline. And then they went into an intervention period where they were using chloride-poor solutions such as balanced crystalloids and albumin. And they found that there was a significant decrease in the magnitude and number of patients developing renal failure when they stopped using chloride-containing solutions. Our study group here out of Flinders then started to drown some of their registrars with various fluids, and they gave normal saline, they gave 4% albumin, and they gave 5% dextrose. And they found that interstitial pulmonary edema in healthy subjects occurred with normal saline, but it didn't occur with albumin, equivalent, the same volume with albumin or 5% dextrose. And it turns out that the sodium potassium chloride co-transporter and the cystic fibrosis transporter regulated ion channels have a role to play in driving fluid into the alveolus using chloride, and it's been found to actually be a major contributor to cardiogenic pulmonary edema. So it makes sense then. So we do have our reservations with normal saline. We've stopped calling it normal saline, by the way. So when we look at this meta-analysis, then 14 studies totaling almost 19,000 patients with sepsis, they said that amongst patients with sepsis, resuscitation with balanced crystalloids or albumin compared with other fluids, and that included starches, by the way, seemed to be associated with reduced mortality. This publication in New England Journal compared balanced crystalloids such as plasmolite against saline and found that, yes, well, your chloride levels are higher with saline, your bicarbonate levels are lower with saline, And they actually documented that whilst there was a strong trend towards better survival using the balanced crystalloids rather than saline, there was definitely a lower incidence of kidney injury using the balanced crystalloids. So again, evidence weighted towards chloride being bad, not just an association between chloride and renal injury. So what do these controversial sepsis guidelines say then? Well, they say we recommend crystalloids as a first choice. Either balanced crystalloids or saline would be a reasonable choice. If they need a substantial amount of crystalloid, then use albumin in addition to crystalloids, and we recommend against using header starch, which is consistent with what we've just said. So what about volume of fluid? Well, atrial stretch causes atrial natriuretic peptide, that's its normal function. And we can see that when you've got low pressure, ANP secretion falls off, and then in response to atrial stretch, ANP release goes up. Unfortunately, you'll remember on that slide when I talked about the things that break down the glycocalyx, ANP was in there. And indeed, when you talk about, so syndecan is one of those proteins that you find in the glycocalyx, and so it's like the troponin of myocardium. If you see syndecan in the circulation, that means that you're breaking down glycocalyx. And certainly with the higher levels of ANP, you get a lot more of this syndecan release. And in this study, what they found was ANP with the vessels really breaks down what you can see. That's what the normal glycocalyx looks like, and that's what a vessel looks like with ANP in there. This is probably one of the most damning studies about fluid boluses that has been published, and it was published called the FEAST trial. Now, I guess its generalisability is perhaps a little bit limited. However, it does give us a strong signal to think about. Children at the time of admission to hospital in Uganda, Kenya or Tanzania, and most of them had malaria with severe febrile illness and impaired perfusion. If they had impaired perfusion, they were randomised to either receiving a bolus of saline, a bolus of albumin, or no bolus whatsoever. If they were severely hypotensive, they got either saline or albumin. And what they found was that the mortality in the no bolus group was much lower than the ones that got the bolus in stratum A, in other words, the ones that had evidence of impaired perfusion. And they found that albumin and saline were equally good at killing these kids as each other. So when we look at these studies looking at fluid balance and outcomes in ICU, we find that a number of studies have been published and a number of meta-analyses and reviews have been performed. And also in other domains, such as looking at the original ARDSNet study patients as well. And the conclusion all swings towards one direction. It favours conservative management. In other words, if you're conservative about the amount of fluid that you administer to the patients, or if you have used a lot of fluid for your resuscitation phase, to do what we call de-resuscitation. In other words, once they no longer need that volume of fluid on board and you've achieved hemodynamic stability and intravascular volume repletion, you should be trying to de-resuscitate that fluid back out of them. There's this notion that the urine output's low, so we've got to give them more fluid and more fluid and more fluid until the urine output is up. And in actual fact, the kidney is an encapsulated organ which undergoes intracapsular hypertension. If you elevate the central venous pressure and you're only aiming for a mean arterial pressure of 65, you've reduced the perfusion pressure gradient for the kidney, and so on and so forth. And so in fact, this notion that you can drown the kidneys is absolutely true. And what we often see in ICU is an edematous fluid overloaded patient whose kidneys are bad, and people say, you surely don't want to give frusemide to that patient. We should be giving them more fluid to try and save the kidneys, and the kidneys actually get better as you get the fluid out of them. And in fact, where we're moving forward into now is we're moving albumin into this era of small volume resuscitation. So again, our researchers are looking into maybe using 20% albumin solution in trying to minimise the volume that we use. And right back to the early 2000s, Neil Soni's group demonstrated that actually the intravascular volume increase that you get from concentrated albumin is greater than you would expect just from the volume itself. Now, with the revised Starling principle, we talked about proteins in the circulation not drawing fluid out of the interstitium, but in actual fact, the glycocalyx occupies a fairly large volume of the intravascular space, and so it may actually draw fluid out of the glycocalyx into the circulating volume without dehydrating the extracellular space. So what do the sepsis guidelines say? Well, the guidelines say that you should use 30 ml per kilo of IV crystalloid in the presence of evidence of poor perfusion, and that after that you should be guided by frequent assessment of the hemodynamic status, and that's best practice statement. And I think, again, that's in line with what we would say is reasonable. So for an average-sized adult, after the first 2 litres of fluid bolusing, have a think about things rather than just banging on with the next litre of fluid. Now, this is the next bit that's a little bit controversial that we'll talk about, guiding resuscitation to normalise lactate. They do recommend a conservative fluid strategy in ARDS, and we talked about that before. We'll talk about vasopressors then. If giving them litre after litre after litre of fluid is not the answer, then what do we know about vasopressors? Well, there are some good things about vasopressin, and you'll see us using a lot of this in ICU, and there's no reason why you can't use it in theatre as well. So vasopressin levels are very low within hours of septic shock onset. And in fact, it has effects in decreasing inducible nitric oxide as well as increasing noradrenaline effect and angiotensin II effect by inactivating the sodium-potassium ATP channels, which reduce cytosolic calcium, which of course is a mechanism of vasoconstriction that adrenergics use. The V1A receptors are also abundant in those sorts of vascular beds that we talk about, septic vasodilatation, such as splanchnics, muscular and cutaneous beds. And whilst noradrenaline constricts the glomerular afferent arteriole, a vasopressin actually constricts the glomerular efferent arteriole and perhaps then might have an effect in maintaining GFR. We can see then in the pathogenesis of vasodilatory shock, one of the major arms then is this reduction in vasopressin release. And also this potassium ATP that we talked about, which vasopressin helps to switch off. We can see that compared with patients with cardiogenic shock, septic shock patients have much, much lower levels of vasopressin. And that those levels, whilst they can be quite high, within hours starts to drop off. However, in this publication in New England Journal of Medicine, when they compared, and this was a blinded study, so they were asked to titrate a blinded fluid to their blood pressure targets, vasopressin did not reduce mortality rates as opposed to noradrenaline. All it did was basically make your fingers turn purple a little bit more often. So that was disappointing, but perhaps we had just not quite found the way to use vasopressin. In this particular study, they found that in the vasopressin administration group, that after vasopressin started to drop off, they had maintained quite good levels of vasopressin, levels that are equivalent to what you might see in other stress states other than shock. So they've done a good job of replacing vasopressin levels. They also then looked at whether vasopressin might help to preserve renal function, and it didn't appear to do so when it was introduced early. So we haven't quite perhaps found the way to use it. There have been a number of meta-analyses comparing different vasopressors, and the conclusion from the guidelines, if you need to know what the guidelines are, is we would start off with noradrenaline. We would then add some vasopressin or perhaps adrenaline. Noradrenaline, generally we would mix 6 milligrams in 100 mils. Therefore, mils per hour on your syringe driver pump equals mics per minute. And then vasopressin, we will use 20 units and 40 mils, which is half a unit per mil, and run it maybe up to about 4.5 to 5 for a standard size adult. Angiotensin II has recently been demonstrated to be quite effective and might be on the horizon as well. So how about steroids then? Never let a patient die without a dose of steroids. So the importance of steroids in stress states has been ever since 1923, where they found that adrenal-ectomized rats did not tolerate infusion of killed bacteria. All the adrenal-ectomized mice died and the standard mice lived. Now you might think, well, maybe they just died from their adrenalectomy, but it was probably identified back then. It has a number of mechanisms of improving vascular tone, including smooth muscle cell receptors. And also, when you put blood vessels with dexamethasone, it upregulates the expression of angiotensin receptors. And we can see in Cushing's patients, for example, their responsiveness to angiotensin and noradrenaline is much higher than in patients without Cushing's syndrome. So why don't we just measure cortisol levels then and titrate the cortisol levels? Well, unfortunately, it's not that easy because serum-free cortisol, which is less than, in normal healthy states, is less than 10% of the total cortisol in the circulation. But as you know, when you become acutely ill, you start to drop your binding protein production, so albumin drops off, cortisol binding globulin drops off, and you start to produce inflammatory acute phase reactant proteins instead. And so if you just measure serum total cortisols, you don't actually appreciate what's going on with cortisol levels. And you can see that in healthy volunteers, as the total cortisol levels increase, the free cortisol actually doesn't increase by that much. Whereas in patients with low albumin levels and severe critical illness, as their total cortisol goes up, their free cortisol really shoots up. So unless you measure free cortisol, you actually have no idea what's going on. We also know that non-survivors have much higher plasma cortisol levels. So the higher cortisol levels don't appear to have a protective effect necessarily. We don't quite know what to aim for. Worse than that still, at a tissue level, cortisol binding globulin delivers the cortisol to the site of action and then is cleaved by neutrophil elastase to release it into the tissues. Once it's gone into the tissues, then cytokines play a role in altering the intracellular metabolism and activation of cortisol. So all of a sudden it really doesn't make sense to measure levels anymore. So what are we left with then? Well, we're left with just picking a dose and sticking to it. So Bala Venkatesh's group then published this paper in the New England Journal this year, the adrenal study, where they used a hydrocortisone infusion for 7 days, fixed dose for 7 days. Well, we don't quite know what to use or how to aim for it, so we're not going to personalise it. We're just going to give the same dose to everyone for the same duration of time, 7 days. What they did find was there was a faster resolution of shock with hydrocortisone. Scientifically, that's exactly what you'd expect. So if you're in trouble in theatre with a blood pressure, give them a shot of hydrocortisone. I would suggest starting off with 100 milligrams. What if we give it its little cousin fludrocortisone? We know that there's cytokine downregulation of mineralocorticoid receptors, and that aldosterone improves the vascular activity of endotoxic vasodilation with vasopressors. And so Anain and his group, the French group, which has published a lot in steroids, then published this paper in the New England Journal and found that there was a faster resolution of shock and multi-organ dysfunction syndrome and better survival when they added 50 micrograms of fludrocortisone to their hydrocortisone. So the Surviving Sepsis campaign suggests that you give hydrocortisone a dose of 200 milligrams per day if fluid resuscitation and vasopressors is struggling to keep up with your blood pressure targets. Now, to talk about cardiomyopathy and troponin leak, of course, this toxic sort of effect on cells includes the myocardium, and of course there's direct myocarditis, which can be due to the bacteria itself, but also free radicals and superoxide radicals. So you do get direct damage to the myocardium and troponin leak, which is not due to cardiac ischemia. But it's not quite that unidimensional. You can get left ventricular systolic dysfunction, you can get right ventricular systolic dysfunction, and you can also get diastolic dysfunction of the left ventricle. And they can all overlap, and they can occur in isolation as well. The guidelines then recommend that you use dobutamine. Pretty simplistic way of looking at it, but that's what it is. So now we start to talk about therapeutic targets. So if you don't know what you're aiming at, then you're almost certainly going to get yourself into trouble. So the Surviving Sepsis campaign says if they've got signs of persistent hypoperfusion, you should use your endpoints reflecting perfusion to titrate your therapy. Now there's a problem here. They want us to use elevated lactate levels as a marker of tissue hypoperfusion. That makes sense in cardiogenic shock, but what about sepsis? So sepsis is a disease of the microcirculation. There's a lot of things going at the microvascular level. So you can make the big vessels as good as you want them to be, and you can make the circulation as good as you want. At the small vessel level, at the tissue level, we've got problems that those won't resolve. This is what microvessels look like in the sublingual space, which is a good area to look at microcirculation. Now, you could argue that maybe it's not due to sepsis, maybe it's due to all the dobutamine they've been giving and how acidemic the patient is. But nonetheless, in sepsis, there is a reduction in the number of functioning capillaries. When you look at, for example, the end organs, you say, well, why don't we titrate it to urine output? When you look at the mechanisms of renal failure and sepsis, this vasodilatation, decreased sort of blood flow to the kidneys is only one of the major pathways that causes renal failure and sepsis. So it doesn't matter how good your cardiac output is and how well you control vasodilatation, you're still going to get renal failure. So what about the liver? Same thing happens in the liver. So you can't say, oh, well, the liver enzymes have gone off, surely perfusion is down. And the same thing goes with the Glasgow Coma score and the neurological function. Again, it is not all to do with the amount of circulation that you're achieving. And so really what they've said is a weak recommendation with a low quality of evidence to start targeting lactate. And it's been well recognised that lactate clearance as a target of therapy in sepsis is a flawed paradigm, and in fact, the adrenaline probably has a lot to do with the lactate production. So those of you who use adrenaline or even salbutamol will know that that puts up the lactate levels, and it's got nothing to do with patients being in a shocked state. And in fact, if you give beta blockers, it drops off the amount of lactate production in muscles. So when you put muscles along with propranolol, you'll find that actually it antagonises the production of lactate. So adrenaline has a lot to do with the production of lactate in sepsis. Not only that, but you also get mitochondrial dysfunction, and you get this uncoupling of the respiratory chain. So even if you deliver the oxygen to the tissues, oxygen utilisation is abnormal. And so what happens then is if you're not utilising the oxygen, then you start to admix a lot of oxygenated blood back into the venous circulation, and your central venous oxygen is quite high. And in fact, if you get quite severe microcirculatory dysfunction and mitochondrial dysfunction, what happens is the patients with very high central venous oxygen saturation actually die more often in sepsis. So it sort of makes it difficult to aim for the SVO2. As it turns out, the SVO2 is a better guide to your tissue perfusion early in the sepsis, maybe in the first 24 hours of onset of septic shock, than it is in the second or third day. And so this early goal-directed therapy, that where we sort of aim for central venous saturations of 70s and so on, there's a flaw in that paradigm where we're looking at lactates and central venous gases and aiming for central venous pressures. Maybe looking at carbon dioxide gap, so the PCO2 gap. You might hear some intensivists talking about PCO2 gap as being a marker of abnormal tissue perfusion. There are some issues with its utility, but it has been proposed as CO2 washout from the tissues. If you've got a very high amount of CO2 in the venous blood as compared with arterial, then perhaps that's evidence of tissue hypoperfusion. What the danger is then is if you say, well, the urine output's low, the liver function's gone off, and the patients become confused, surely that's evidence of hypoperfusion. If you then use dobutamine to drive up the cardiac output and oxygen delivery to tissues, you may actually worsen their survival, and that's exactly what has been published in the New England Journal before. So what that means then is how much of this abnormality that we're seeing is amenable to fluids and vasopressors, and in fact the traditional markers of tissue hypoperfusion are more difficult to interpret in sepsis than, for example, someone with heart failure and hypotension. So then we look at this and we say, all right, well, this is pretty simple. Hypovolemia, I give them saline, maybe a bit of albumin, throw in a bit of plasmolite if the hospital's got an unlimited budget. They've got reduced vascular tone, so I give them noradrenaline, maybe throw in a bit of vasopressin, and I'm getting some hydrocortisone and stick a nasogastric down and give them some fludrocortisone, and then I just titrate some dobutamine. That's pretty simple. What else is there to it? We've got guidelines that makes it easy. Is that all you've got? Well, to put it in this way, you've now mastered the art of treating septic shock, but now you have to learn how to treat shock and sepsis. So why are the two different from each other? This is Takotsubo cardiomyopathy. It's called broken heart syndrome. And essentially, sepsis, unfortunately, is a common precipitant of Takotsubo. And not only is cardiac catecholamine toxicity implicated in it, but also exogenous administration of catecholamines can actually bring on Takotsubos. So this is an image of Takotsubos that has been brought on by use of beta agonists, such as dobutamine. And in this case, it was dobutamine. So it turns out then that there's this international expert consensus that looks at Takotsubos, and they've basically said, well, beta blockers aren't helpful, levosimendan maybe it's helpful, beta blockers not helpful, statins not helpful, maybe we should give them ACE inhibitors, which is a really good agent to give in septic shock. And then they said if the patient's got Takotsubo, maybe we should be avoiding adrenaline, noradrenaline, dobutamine, murinone and isoprenolol. Well, that doesn't make treating septic shock very easy, does it? So the take-home messages really are not only is sepsis, particularly bacterial sepsis, a common cause of Takotsubos, and it mimics myocardial infarction. They get chest pain, they get a troponin rise, they get ST elevation on their ECGs. It may be caused by and worsened by catecholamines. About 20% of them will have a left ventricular outflow tract obstruction, and you'll make that even worse by giving them more inotropes, and they really need lots of fluid and vasopressors to maintain that left ventricular outflow tract. It's also strongly associated with long QT syndrome and arrhythmias, particularly if you've got a corrected QT interval of more than 500 milliseconds, and then you think, well, maybe we should be using beta blockers to try and open up that left ventricular outflow tract. And maybe we need to give them ivermectin to slow the heart down a little bit. But of course, slowing the heart down with these measures increases the QT interval and might actually precipitate arrhythmias and takotsubo. And so maybe you'll need to find a place for ECMO in these sorts of patients. So we've talked about heart failure and raising troponin may not necessarily be a coronary artery, but maybe it is a coronary artery. You say, oh no, of course not, the troponin rise is just sepsis and renal failure. What else could it be? One of those scary sort of looking diagrams that I showed you up the top talked about the pro-inflammatory response. And as it turns out, endothelial function is intimately involved in coronary artery disease, and we know that sepsis is a disorder of the endothelium. Not only that, but it turns out that the pathogenesis of atherosclerosis is also tightly linked with inflammation, and as does atherothrombosis. So all of a sudden we've got a problem here. We've got a patient who's got systemic activation of inflammation and a condition which is highly sensitive to inflammation. It turns out, in fact, that CRP is one of the bad guys in here for coronary artery disease. And more bad news then is systemic infections cause exaggerated local inflammation in atherosclerotic coronary arteries. And we can see that in coronary arteries that the infiltration of white cells is quite marked in the presence of sepsis. So we've got these diseased coronary arteries that are packed full of inflammatory cells. And there's a whole host of ways that sepsis can affect atherosclerosis. Platelet activation also occurs, as we talked about, in endothelial dysfunction, and that's obvious. And as you know, platelet activation and adhesion is the first step to having a myocardial infarction. And so it's been observed that in acute infections, but not in vaccinations, such as systemic respiratory tract infections like pneumonia and UTIs, this publication in New England Journal found a much higher odds ratio of having a myocardial infarction if you've developed one of these conditions of sepsis. And in fact, pneumonia is such a strong stimulus of myocardial infarction that a number of publications have come out about this, particularly in the first few days of coming in with pneumonia. And this effect actually lasts for quite some time. When you look at these longitudinal studies of after someone's recovered from an episode of pneumonia, how often they will come in with cardiovascular disease, particularly in the early phases, they are very prone to having myocardial infarction and stroke. Influenza virus also infects atherosclerotic plaques, and lo and behold, publication earlier this year in New England Journal talking about viral infections, not just influenza but also RSV infections. The incidence ratio of myocardial infarction after being confirmed diagnosis of influenza or RSV is very high. Now, this is a condition that you really don't want to miss, acute cor pulmonale. Why on earth would they get acute cor pulmonale? So we talked about those microcirculatory changes that you get. Of course, in the lungs, the same thing can occur. You get microthrombi, hypoxemia and hypercapnia, of course, will worsen pulmonary hypertension. You get edema, and then, of course, our ventilation can contribute. If you underventilate the patients, they'll get a reduction in vascular diameter and an increase in right ventricular failure. And if you stretch the lungs too much and distend them, you'll do exactly the same. And so you get this de-recruitment sort of increase in right heart failure, but if you over-recruit and over-distend the lungs, you also get this right heart failure. So you have to get the peak just right in these sorts of patients. It turns out then, and it's no surprise, that the presence of right ventricular failure in sepsis is a bad prognostic sign. Be very careful that PCO2s of greater than 60 are strongly associated with not just cor pulmonale, but if you start to raise the pressures on the right side of the heart, remembering that close to 20% of the normal population of people have got a patent foramen ovale. And if you elevate the pressure on the right side of the heart, you start to create a right to left shunt. And what does that do? Well, it worsens the oxygenation. So the higher you turn up the PEEP, the worse the oxygenation of the patient gets. That's just a video of a bubble study that we'd done that you can show when you inject bubbles into the heart, looking at a four-chamber view, the bubbles very quickly appear on the left side, and unfortunately the video is not. Okay, so acute cor pulmonale can open up a right to left shunt and it can worsen your oxygenation. And it's also worsened by ARDS ventilation. So when we use ARDS ventilation, we of course have permissive hypocapnia, we use low total volumes, and we use high PEEPs. And when the patient's condition deteriorates and their blood pressure can't be held up, we have to look for acute cor pulmonale and right heart failure as a cause for refractory hypotension. Fluid loading, of course, then can be very dangerous because it causes a further decrease in left ventricular filling by shifting the septum across to the left ventricle. Of course, the rise in central venous pressure then also decreases organ perfusion pressure and increases systemic congestion, and you also increase right ventricular ischemia, and again, you'll get a troponin rise from the ischemic right ventricle. Now, prone positioning is said to unload the right ventricle in severe ARDS, and again, this is another situation where you might be backed into a corner to give the patient ECMO. So what about temperature management then? Can that help? Well, you remember when your mum used to say, go inside before you catch a cold. And what she meant to say was, go inside before you get a fall in your white cell count and function and a loss of heat shock protein downregulation of NFK beta nuclear transcription factor expression of pro-inflammatory cytokines and INOS induction. But we all know that in the absence of fever or hypothermia is equal to a bad thing. So the patients that do actually the best in sepsis are the ones that will mount a fever. And fever means something different to prognosis in the presence of sepsis. So we see that in patients who are not septic, the higher temperatures portend a very poor prognosis, but not so patients who have got infection. And in fact, in this group, when they studied Ronaldo Bellomo's group again, they found that the patients with the lowest risk of dying from sepsis had a peak temperature in the first 24 hours of somewhere around 38 to 39 degrees. But we do know that febrile range hypothermia also causes more lung injury. So we have a look here where we find that when we do BALs in rats that are hot, they've got a lot more polymorphoneucleoleucocytes, white cells in their albumin, in their alveoli, and also their protein concentrations are much higher. So there's a lot more lung injury that goes on when the patient is hypothermic. And in this particular trial, they lowered patients' temperature and septic shock and found that it was effective in reducing vasopressor requirements. So when you've got this patient with this raging temperature and you can't keep their blood pressure up, it can actually help then to cool them down a little bit. And they documented a lower mortality in their group. Now, this is not a universal finding, so we don't all aggressively control fever, but this was just one group's findings. However, hypothermia is not such a good thing. So in this particular study that was only just published in Lancet not long ago, there was a concerning effect on mortality with hypothermia. So yes, they cooled the patients down very effectively, but with a p-value of 0.07 with a higher mortality in the induced hypothermia group, it raises some concerns about it. Not only that, but it also increased the need for vasopressors and inotropes. So when the patient is cold, it does not help their inotrope and vasopressor requirement. So what about renal replacement therapy then? We know that we can remove cytokines in ultrafiltrate fluid by dialyzing patients, but unfortunately the circulating cytokine levels don't seem to have changed by using what we would call a standard dose of dialysis, 25 mils per kilo per hour of ultrafiltrate. And indeed, it's not effective in reducing vasopressor dependence. And then what if we turn it up to 11 and we turn it right up? Higher volume hemodialysis may improve blood pressure in acidosis. So in this group, again in Ronaldo Bellomo's group, they found that when they used higher doses of dialysis, they found that even though the effect on acid base was exactly the same, there was in fact better blood pressure in the high ultrafiltrate group and a lower need for noradrenaline. So dialysis is one way of making your noradrenaline requirements good. But when you do high intensity hemofiltration, you do increase antibiotic clearance as well. So in this particular study, the Iviore study, they found that all antibiotics were easily filtered in the ones that were used in the study. Polymyxin B adsorption of toxins has been studied, but as you can see in these, even when they do a meta-analysis, there's not a lot of very good data out there, so it's still in its early phases. So what about giving the patient a shot of bicarbonate? It does appear as if their pH is less than 7.15, maybe try the bicarb. In these sorts of studies, it's got a very mixed review about whether it's effective, but I can tell you that I've managed to salvage blood pressure using shots of bicarb in very acidemic patients before. So it's quite remarkable the effect that you'll get in blood pressure when you give patients a bolus of bicarb. So what about nitric oxide? And we're talking about how evil nitric oxide is. And we know that by inhibiting nitric oxide, we can restore some responsiveness to inotropes and vasopressors. But the problem with nitric oxide, of course, is it's actually got some vital functions in the body, and you actually antagonise a lot of them when you inhibit nitric oxide. And it turns out that in nitric oxide knockout mice, they don't survive sepsis as well as mice that can induce nitric oxide. And in this particular study using a nitric oxide inhibitor, the trial was stopped early due to an increase in 28-day mortality, a lot of pulmonary hypertension, a lot of decrease in cardiac output and cardiac failure that occurred with nitric oxide inhibition. There is another way to attack the nitric oxide pathway, and that's methylene blue. So those of you who do cardiac surgery will know that in the old days they used to use methylene blue to get the patients off pump and into the ICU so they could die there instead. It is essentially a downstream effector mechanism of nitric oxide, so maybe it doesn't antagonise some of those useful effects of nitric oxide. Essentially the dose would be 1 to 4 milligrams per kilogram over 15 minutes, and it may well help you get the patient back to the ICU for other things to happen after that. But yes, you can get pulmonary hypertension. It does inhibit hypoxic pulmonary vasoconstriction, and it can cause a few other things, and your sats go sour and your patient looks like a smurf. It is a monoamine oxidase inhibitor though, so if the patient does have antidepressants on board, you have to be careful that it can precipitate serotonin syndrome. It has been linked to fetal hypoxia in pregnancy, and it increases hemolysis, of course, in patients with G6PD. So then come the statins. Of course, there's interest in statins. So maybe statins, not only does it preserve the inducible nitric oxide function, the endothelial nitric oxide synthase function, but it selectively downregulates iNOS. So maybe statins might be useful in that regard. Now, here's a trick question. Can giving more antibiotics, improve the patient's blood pressure? I wouldn't ask that if the answer was no. But it's a bit cryptic because it's not quite that direct. So we know that stress induces endotoxemia by increasing gut barrier permeability, and that's just by sympathetic nervous system activation. But we do know that the gut barrier is lost in sepsis, and all of that hypoperfusion and microvascular dysfunction breaks down the gut barrier, and bacteria can translocate into the circulation. And actually translocations are part of normal life, so it'll get mopped up by the lymphatics, and those bacteria that enter the circulation will get mopped up by the Kupffer cells in the liver. But of course those mechanisms are overwhelmed in sepsis, and actually you can get translocation of gut bacteria. And as we know from Kumar's publication, as we say, time is myocardium, myocardial infarction, well, time is survival in septic shock. So if you don't get effective antibiotics into the patients quickly, their survival drops off. And so you'll find that in intensive care, when the patient is going down the gurgler, we give them broad spectrum antibiotics to make sure that that phenomenon of sepsis not being covered by appropriate antibiotics is not there. Also, there's altered antibiotic pharmacology. So whilst you might be used to your standard dose of antibiotics working, we do have to take into account that the pharmacokinetics of antibiotics is very variable and quite often markedly deranged in patients whereby the concentrations can be disappointingly low using standard doses of antibiotics. ECMO has been trialled. The results have been disappointing, but there are certain patients with certain indications which I would not hesitate to use ECMO if I found. So ventilation strategies, this is really my last point. This is relevant to anaesthetists because quite often you guys are ventilating septic patients in theatre. Should lung protective ventilation only be used for established ARDS? In rats without ARDS, if you compare two different ways of ventilating them, if you ventilate them with high tidal volume, low PEEP versus low tidal volume with high PEEP, and then expose them to lipopolysaccharide, which of course is an endotoxin, you get a lot more lung injury if you're giving them the high tidal volume, low PEEP ventilation than if you gave them the low one. So this is just straining the lungs, this is straining them with lipopolysaccharide, and this is exposing them to lipopolysaccharide but with low strain ventilation. So if you have a septic patient in theatre who does not have ARDS, perhaps there is a role for using lung protective ventilation in those patients as well. Vitamin C, yes, there has been some stuff published about vitamin C having a number of favourable effects in the body, and that it will be trialled in the future. So in summary, there are some slightly controversial guidelines that exist, and guidelines are conditions, but clinicians are for patients. We've talked about fluids, we've talked about vasopressors, inotropes, steroids and targets in sepsis. We've talked about other cardiac causes of shock in sepsis. We've talked about tacosubos, left ventricular outflow tract obstruction, sepsis and acute coronary syndromes, acute pulmonale and ARDS, patent foramen ovalis and right to left shunts. We've talked about fever, maybe lowering the patient's temperature can help you get them down in vasopressors. Blood purification using renal replacement therapy. We've talked about maybe using bicarb. Nitric oxide antagonism with methylene blue. More antibiotics and considering things like pharmacokinetic changes and GI translocation, and lung injury and ventilation. So I did promise you that I would give you something good to take away with tonight, and that is the med student just asked me a question and you say, well, this is just the way that we've always done it. This is how you answer the question if you're an intensivist. You'll be 80 to 90% safe if you answer it with, our understanding of the science is incomplete. Small studies have shown inconsistent results and are inconclusive. ANZIC's performed a large-scale, multi-centre, randomised controlled trial looking at this and found no difference in primary or secondary outcomes, so more studies are needed. So this is just the way we've always done it. Thank you.
Unless anyone has any pressing questions, I'd like to thank Steve for coming along tonight. Thank you very much. And thank you all for your attendance, and we'll see you next time.